I'm Drew. I'm going to be talking about placebo analgesia today. This will be the history, the mechanisms, some clinical applications that we can use, and really some ways that patients can benefit from placebo. So first off, a little bit on pain. We know that it's a huge problem in this country. Over 10 million people suffer from chronic pain. This doesn't include acute pain. Subacute pain costs the economy billions of dollars a year. And we know a lot of what we do for pain has some adverse effects. We have medications which can have some negative side effects, some injections which can have some negative side effects. And so in that context, something that is inert that could have a benefit for patients has a certain amount of appeal to it. So before we get too far, I just want to define our terms. So these are from Webster's here, but placebo is usually a pharmacologically inert preparation prescribed more for the mental relief of a patient than for its actual effect on the disorder. And placebo effect is improvement in the condition really based on that placebo, but can't be considered due to the specific treatment. So those definitions may need a little bit of updating, but it's a good place to start. So the question becomes, is a doctor who uses placebo participating in quackery, or are there cases where it might be reasonable to do? And is the patient that benefits from a placebo, are they a sucker, are they a fool, or are they a powerful healer able to channel things within themselves to get rid of pain? So briefly, I want to go over the history of placebo. The word is Latin. It means I shall please. It was first seen in the Bible, Psalm 116. Placebo domino in regione vivorum. So I shall please the Lord in the land of the living. This was a very popular psalm at funerals. And there became this practice of hiring fake mourners to come to funerals to make people look more loved or more important. And those people sang this psalm and became known as placebos. So very early on in the history of the word, we have both the I shall please aspect and the, there's something not quite legitimate about it. So those definitions have been with us for a long time. It didn't appear in medical literature until 1785. The first definition we see is pretty vague. It just says a commonplace method or medicine. But in 1811, we see a more modern definition, meaning an epithet given to any medicine adapted more to please than to benefit the patient. We have what was likely the first, or at least the first documented control trial done in 1801. A gentleman named John Haygarth wanted to challenge a common practice of the time called Perkins tractors. They were these metal rods that were rubbed over the skin and were supposed to relieve pain. It actually sounds a little bit like Graston. And what he wanted to say is that he didn't think it had anything to do with this special alloy. So what he did was he made wooden tractors, painted them to look like metal, and then used them on the patients. And what he found was that he got the same results as the metal tractors. So what he took away from that was not as much that he had proven something was illegitimate, but his takeaway was the powerful influence of the passions of the mind upon the state and disorder of the body. So really, he's talking about the placebo effect. This quote I thought was interesting in how much it showed that placebo was really a usual part of medicine, really into the mid-20th century. And Richard Cabot was a Harvard physician basically saying that everyone was taught to use placebo. The guy who really brought placebo and placebo effect into sort of the medical language in a more scientific way was a gentleman named Henry Beecher. He was a medic in World War II. The way the story goes is that a patient came in with a gunshot wound. They had run out of morphine. And the nurse decided that she was going to give the patient saline instead of morphine because they didn't have it, and just tell him it was morphine. The patient had a great response, did not go into shock, and they state that they saved him from by using saline. And so this experience really stuck with him. So in 1955, he wrote a piece called "The Powerful Placebo," which really brought the the term placebo effect into the language, where he looked at 15 controlled trials and showed how well the placebo group actually did with no legitimate treatment. 1962, there's a lot of concern about the safety of medications in this country. The thalidomide birth defects, were well publicized at this point, and the population of the country really wanted to be sure that the pharmaceutical industry was doing everything that they could to make things safe. So the Food, Drug, and Cosmetics Act of 1962 really set forth the randomized controlled trial as the standard for getting pharmaceuticals approved. And it officially made placebo effect a hurdle that pharmaceutical companies had to overcome in order for drugs to be approved. So placebo now, if you do a PubMed search, you'll see over 186,000 articles. I did not read all of them, but most of those are in the context of randomized controlled trial. More of them are starting to be about other uses for placebo for treatment. So there's recent studies that have shown that between 45 and 80% of US physicians already use placebo in their practice. 96 of those surveyed believed that placebos had a therapeutic effect. 12 thought that it should be banned in clinical practice. 6 said they used it for pain. And at this point, it's important to make a distinction between pure and impure placebos. When we think of placebo, we generally think of a sugar pill, and impure placebo is something that has an effect, but not for the condition it's being prescribed, or not at the dose it's being prescribed. So something that you knew was viral, for example, but you prescribed an antibiotic just to make the patient feel better, that would be considered an impure placebo, just to make them feel better. So in the journal Pain last year, Tuttle et al. Did what I thought was a really interesting analysis. They compared 84 trials of placebo versus neuropathic pain medications. And what they were able to determine was that patients seemed to have a pretty steady response to the active medications over that time. From 1996 to 2013, it was a pretty flat line. However, the placebos that they were being compared to got stronger and stronger. In 1996, 27% was the margin between placebo and active medications, where that fell to just 8.9% in 2013. And when they looked at this even further, they saw that the change was really only in the United States trials. There was a gentle curve everywhere else, but this blue curve here, which is the level of improvement due to placebo, was really more dramatic. The pharmaceutical companies noticed this as well and started something called the Placebo Response Drug Trials Survey, and started sharing data with each other in order to figure out ways that they can design trials that have decreased placebo effects so that it would be easier to get drugs approved. Now, there's some different theories as to why this is occurring, but the one that I thought was most interesting was direct-to-consumer advertising. The United States is one of 2 countries that allows pharmaceutical companies to directly market their products to consumers. And as we'll see with placebo, association and conditioning has a lot to do with why this occurs. So as a population, we are exposed to the message that pills equal relief, to the point that it might not matter what kind of pill it actually is. So the pharmaceutical company the companies may be finding that they're victims of their own success. So I pulled out a couple interesting studies and meta-analysis that I think illustrate some interesting points. So in Pain and Therapy in 2014, Mercier et al. Published a study comparing tapentadol versus tramadol and comparing that versus placebo. There had not been head-to-head trials, so they took these 83 studies, 45 of which met the inclusion criteria, and this represented about 13,000 patients. And they really wanted to take a look at what their pain looked like over time and what the adverse effects looked like. And what they found was that the tramadol had a better effect on pain. Tapentadol had a reduced effect, or had less adverse outcomes. So they really said overall risk versus benefit, they consider them to be pretty equal. But for me, the sort of sleeper story in there was how well placebo did compared to those two. So everybody started with a baseline pain of 6.9, and at 12 weeks, there was a comparison made. So there was a 3.7 was the pain scale out of 10 for tramadol, 4.3 tapentadol, and 4.8 with placebo. So really the best active drug and the placebo had a 1.1 on a 10-point scale difference. That's a significant difference. However, when you consider that all of the side effects were 2.5 to 4 times more likely to occur in the active medication group, then there becomes an argument for, if we're doing a risk versus benefit analysis, that the placebo really has something to offer there. But it was this diagram that made me think I really need to include this study, because I looked at it and my first thought was, well, which one is the placebo here? And so if you look at the time course and really how it plateaus and even the shapes of the curve, the magnitude of change in the tramadol group is definitely larger, but the overall pain intensity time course really goes about the same until measured out to 12 or 15 weeks. Another study at the end of 2015, it was in BMJ by Jonas et al. They did a meta-analysis of sham procedures versus actual procedures and surgeries. And what they found was that overall, 65% of the effect of the genuine surgeries could be chalked up or could be achieved by placebo. So just by making an incision in the skin, 65% of the benefit was achieved. Now, when this was broken down to looking just at the pain part of this, there was a 78% effect. So sham procedures were able to achieve 78% of what the actual the actual procedures were able to do. So they were looking at things like facet joint neurotomy, vertebroplasty, among others. Certainly, some of these are studies that they needed to look at against placebo to begin with, but it is I thought it was a pretty interesting analysis there. This one here, no one comes out looking particularly good. This was in the Archives of Internal Medicine, and they did sham acupuncture versus traditional acupuncture. This was in Germany, and they took over 1,000 people, split them into 3 groups. They gave one group traditional acupuncture, one group sham acupuncture, so needles in places that had no significance in any form of medicine, and then conventional therapy. So traditional acupuncture versus sham acupuncture pretty much had the same outcome. It doesn't say much for acupuncture there. In the conventional therapy group, 27% of people met their outcome goals. So I'm sure this was not Temple Moss quality physical therapy here that these patients had. But regardless of what you think about acupuncture, regardless of what you think about therapy, 44.2% of the patients that participated just had needles stuck in random areas and achieved their outcomes. So a very strong showing for placebo there. 2001 New England Journal of Medicine meta-analysis of the placebo effect was done, and really to cut down to it, they said that they felt that there was no real significant effect of placebo, except in subjective outcomes, continuous subjective outcomes, and for the treatment of pain. So even in this article that has a lot of things saying that placebo is not very significant, they do make an exception for the treatment of pain. And if we believe the other study that was done about the increasing effect of placebo, we've had another 15 years for the placebo effect to actually get stronger. So what's actually happening here? Why is there an effect with placebo? I'm sure a lot of thoughts have been coming up in people's minds at this point, explaining things away, and I'll like to address some of it. So some of what happens between the top here, placebo, and the actual improvement that occurs is going to be the natural course of the disease, that we can't take credit for something that time was going to take care of anyway. There can be biases in the way things are reported or the way statistic analysis is done. And really what I'm going to be talking about next is these psychobiological factors. So expectation, learning, a little bit on genetics, and really what's happening inside the patient. So the experience of pain is a pretty complex one. And there's certain parts of the brain that are very important to discuss in the way that that patients experience their pain. So the prefrontal cortex seems to play a big role in the expectation of pain. Orbitofrontal cortex has to do with really what the response to pain is going to be. The limbic system plays a large role in sort of the meaning that's attached to it, the emotional impact of the pain that we feel. We've got the somatosensory cortex, which really has to do with localization of the pain. But all of these parts of the brain I had been familiar with, but something that I kept coming up and I hadn't really seen too much before was the periaqueductal gray. And what's important about this area of the brain is it has a large amount of endogenous opioid-producing cells and descending fibers to the spinal cord, and we'll talk about why that might matter. Gaffo is a researcher, and he broke the ways placebo influences patients down into really three main phases. First being induction, so really the therapeutic message that they're exposed to, the beliefs that they bring into the room, the enthusiasm that the physician has, all of those things sort of interacting. That mixing with the psychophysiological mediators, so conditioning, cognition, motivation, emotions, we'll talk about all of those. And then really what happens inside the brain, so that neurophysiological process. And all of that adds together for the actual effects. So is this lower pain scales? Is this less medication being taken? Is the quality of life of the patient improving? So in that phase 2, conditioning theory was listed there. And that's really classical conditioning. That's Pavlov's dog. That's direct-to-consumer advertising, that we associate one thing with another and we're able to produce an effect. There was a study that I came across where patients who had been taking aspirin for a long time for pain relief were able to be given something that just tasted like aspirin, and were able to have benefits for it. So that would be an example of conditioning theory. And it's not limited just to medications. People can have associations with their doctor, their doctor's office, white coats in general, and all of those can be a part of that conditioning. Then there's expectance theory. And that's really that people that expect to improve are more likely to improve. That's part of the setup for placebo. So people can be influenced by the size, the quantity, the color of their pills. And there's been studies showing all of these things, that the more pills people take, the higher the level of placebo effect that they have. That there's something about that therapeutic ritual that seems to bolster that effect. Motivation theory is that patients have to really want to get better. I'm sure that's something that we've already come across in our experience, that patients who want to improve seem to. There was an interesting study with irritable bowel syndrome patients that had painful symptoms, and what they did is they reproduced some of the pain by creating a rectal stretch in the lab, and they were able to calibrate that on a scale of 1 to 10. Then they also gave pain in the foot that they were also able to calibrate to 8 out of 10. And what they found is that when they gave the patients the placebos, it was more likely to produce placebo analgesia for the rectal pain, the pain that meant something to the patient, that they had a motivation for there to actually be an effective treatment for, than it did for this foot pain that they didn't really have any kind of real skin in the game, so to say. So that really having a motivation for a particular thing to work makes a statistical difference. Emotions theory really is almost pop psychology at this point, but that stress, anxiety, depression, all of these things upregulate our pain, and that the converse of this works for placebo effect. So the calmer, the more relaxed the patient is, the more robust the placebo analgesia response. Back into sort of the first phase that was on that Gaffo diagram there is personality traits. So certain personalities tend to respond to placebo while others do not. Optimists, people that are less anxious, people that have hypnotic susceptibility, that although you probably won't necessarily know that in your office. Somatic focus, so people that are really sort of inwardly focused. They talk about how much they know their body and what works for them. Empathetic patients, neurotic patients, and altruists in different studies have all shown to have a higher placebo analgesia response than others. Genetic theory, I just want to sort of touch on briefly, but basically a few alleles have been isolated as to robust responders. So people that have these particular mutations for one reason or another seem to be very susceptible to placebo analgesia. So all of this is a little sort of wishy-washy, where you have the patient, they're exposed to something happens in the body, and then they feel better. So there's sort of a black box that covers the middle part of the equation, and the first guy that really started to shine a light into that black box was this gentleman, Levine, who published in The Lancet back in 1978. And what he was able to show was that if naloxone was given prior to trying to induce a placebo analgesic effect, that it totally nullified the effects. The patients were unable to have placebo. So the conclusion there was that endogenous opioids were actually participating in this, that they were mediating the placebo analgesic effect. So the next generation of these studies, when technology improved, was really with fMRI. There's a gentleman, Tor Wager, who has done a lot of these studies. This is the first one that was published back in the journal Science in 2004. And what he wanted to do was see what happened within the brain while placebo analgesia was being experienced. And they had a couple hypotheses. They said that if placebos really do change the experience of pain, then the parts of the brain that experience pain should have decreased blood flow or activity during placebo analgesia. And that if anticipation plays into it, that areas in the brain that have already been identified to be active in expectation should have increased levels of blood flow prior to the analgesic effect. And so the way that they tested this is they had 24 participants that were already screened that were known to be placebo responders. They said during a study of brain responses to analgesic cream, they put them in an fMRI, and they gave them 15 shocks on their arm. Each shock was 6 seconds long. There was a red icon for strong shocks, a blue icon for mild shocks. And for the first one, there was no cream. So they were shocked these 15 times. They're asked to rate their pain each time. In blocks 2 and 3, they were given a cream. They said that this will reduce but not eliminate your pain. The same procedure was done with the 15 shocks. And then finally, blocks 4 and 5, they wiped off the first cream, put a new cream on, and said, this cream has no effect. And they also had them rate their pain. And what they found was that every participant had a statistically significant decrease in pain with the intense shocks. With the mild shocks, it didn't seem to play a difference. Again, sort of speaking to that motivation theory involved in placebo. So they were also able to isolate the areas of blood flow. So as was predicted, the prefrontal cortex and the orbital frontal cortex, which are involved in the anticipation of pain, they had increased blood flow, as did the periaqueductal gray, which releases those endogenous opioids, which would explain the actual effect. There was decreased blood flow in the anterior cingulate cortex, the insula, and the thalamus, all involved in the experience of pain. And what was beyond that, the reported pain directly correlated with how much reduction there was in those areas. So the less blood flow in those areas, the lower the pain scores. Part 2 of that study, they wanted to look over a time course. So they used a different kind of pain. This was a heat pain. So they had 24 participants again in the fMRI. The major difference between this one was that there was a manipulation phase. So they had, on one arm, they had the control cream and they had the placebo cream, and the patients were told this is active. And it's very strange to talk about these things with the placebo is not the control, but you'll get used to it. So there was the placebo cream and the control cream. So the placebo cream, they said, all right, this is going to reduce your pain here. And they exposed that area of the skin to 2 out of 10 heat. And then the other area of the skin, which was supposed to be the control, was exposed to 8 out of 10 heat. So the patient began to associate this cream is really doing a great job reducing my pain, because they believed that it was equal. Then there was a break. They switched arms. They went to the other arm. They applied the placebo cream again and the control cream, and then they really did expose them to equal amounts of heat, and found that the patients still consistently felt like the placebo cream was reducing their pain. So there was a reduction of about 22% compared to the control. The same brain regions were active during this, but the longer time course allowed them to look at sort of the flow here. So the prefrontal cortex and the orbital frontal cortex were activated first, really showing that anticipation was important. Then the anterior cingulate cortex, and then after the pain went on a little bit longer, that's when the insula and the thalamus started to kick in. So in 2014, a meta-analysis of all of these types of studies was done. They took 25 fMRI or PET scan trials, and they found really that what was found by Torwager in that first study was very reproducible. They broke things down a little bit further. Instead of the prefrontal cortex, it's the dorsolateral prefrontal cortex. But really overall, other than parsing things a little deeper, they found the same sort of thing. So during the during the expectation, we see the dorsolateral prefrontal cortex here, the orbital frontal cortex here, and the periaqueductal gray region, all with increased activity. The thalamus and the anterior cingulate cortex up there with decreased blood flow. That decreased blood flow also remained lower during the actual experience of the pain as well. So there are some other possible additional placebo mediators that are less studied at this point. Endocannabinoids seem to be playing a role, as well as dopamine, but are less researched at this point, and would probably need another hour. It would be I would be remiss talking about placebo if I didn't talk about nocebo. Nocebo is the evil twin, and basically that the suggestion of a negative outcome producing a negative outcome. This was first described in 1962, and a recent study that showed this effect was by Kalaka in 2008, and she basically was able to show that the she could turn a non-painful stimulus into a painful stimulus just with the verbal instructions that this is going to hurt. Now, the mechanism believed to be involved here is the cholecystic, the CCK system here. And by administering proglamide, which is a CCK antagonist, they were able to prevent nocebo hyperalgesia. So just like Levine did the naloxone study, this is sort of the counterpoint that Benedetti did here, showing that both of these really are brain processes. Obviously, it's important to talk about the ethics of placebo in clinical trials, or I'm sorry, clinical practice. So this is probably not a great ethical argument for the use of placebo. Can we do it for pain management? So there are some policy statements that different organizations have put out, and to summarize this all down, they basically say don't do it. So the AMA, the AOA, the American Nurses Association, the pain management nurses, they all say no with some caveats. So the AMA basically says that if the patient agrees to it and knows that it's happening, then you can do it. Otherwise, it will undermine trust, and the patient-physician relationship could be challenged. I thought it was interesting in the ANA website that they really said that it should be refused, that if you get the order to administer one, that you should actually refuse to do the medical order. So in this context, well, how do we proceed? So in the Journal of Pain 2015, Kisalida did a study where she took patients that really had no experience with, they were chronic pain patients. They compared patients that got a 5-slide education about placebo and sort of how it worked versus patients that just got a 5-slide lecture on pain. And basically, they found that these participants that understood that there really was something happening within the brain across all categories felt that it was reasonable to use placebo, and that they would be okay even themselves receiving placebo. The one caveat there was that they didn't like the idea of using it to diagnose pain. So if I don't think your pain is real and I give you this placebo and you feel better, then I've proven that your pain wasn't real. That was the context in which they felt was not legitimate. But the patients that just received the presentation on pain were still very against the idea. So the ethical arguments against the use of placebo are pretty easy to make. You've probably been making them in your heads. The one that I thought that countered that was most interesting was this guy Glacken in the Journal of Medical Ethics last year, and he comes up with this idea of the grip of the false picture. Basically saying that not all the information that we give patients actually helps to really educate them and have them make an educated choice. So if that patients are in the grip of what he called naive Cartesianism, so blaming Descartes here for the mind-body split, that if patients really believe that something that affects the mind can't affect the body, by giving them the information that this is something that has no active component for the body, they may think that it will then have no effect. So by giving them that information, we're actually making them less likely to choose something that may be in their benefit. And that in other cases, we bottom line things for patients. We give them an opiate, and we say that this is for your pain, but we don't necessarily say this is going to, we don't talk to them about their mu receptors. We don't talk about what's going on in the nephrons when we give diuretics. We just say this is going to help with your blood pressure. So, is it actually important to give patients this part of the story? Maybe, maybe not. So there was a response in that same journal, which basically they said that our responsibility as physicians is to give patients the information. And if they make a decision that's not in their own best interest, well, that's really up to them. That we can't be held responsible for what they do with the information that we give them, and that we really need full disclosure in order for there to be ethical use. So, that question remains. We've seen what placebo does inside the brain. We see that there is a legitimate opiate activation. Are they different than other medications? Do they need a different standard by which we provide informed consent? So how do we do this? First, I want to say these are ideas that based on what we've talked about so far. So what we can these are really what I think we can do. So pure placebos are probably out. There was a guy writing for Obacalp in Australia. He was the first one to do it. That's placebo backwards. And it would not take very long for people with Google now to figure out what's going on here. So most people will take things home. So if you're relying on deception for your placebo effect, it's probably not going to happen anymore. Maybe 25 years ago. So what are some options? There was a French study in encephaly in 2003. Unfortunately, it was not a pain study, but it was a placebo study. They took anxious patients or patients with fatigue, and they gave them placebos, telling them that it was a placebo. So this has no active ingredient in it. The anxious people got blue pills. The tired people got red pills. And the outcome measure was 50% of their symptoms to decrease over the course of the week. And they found that 18 out of the 34 patients, knowing they were taking a placebo, met that outcome measure. And 4 had to drop out from side effects. There's some nocebo happening there, I guess. But that really shows you the power of this inert substance. In the Journal of Pain in 2015, there was a study that did conditioning like the fMRI one before, where there was the 2 creams that people were conditioned to. So this was they were conditioned to believe that one cream was actually working. They had one group conditioned for 1 day, and they had another group conditioned for 4 days. And what then they were told, oh, by the way, that cream that you're getting relief from, it's just a placebo. There's nothing going on there. The patients that were conditioned for 1 day, placebo effect totally disappeared. The patients that were conditioned for 4 days continued to have placebo effect for another 25 minutes after. And they didn't test after that. I think that was a real missed opportunity to see how long this really would have lasted. But at least after the reveal, the placebo effect did remain. So here are some potential models for placebo without deception in clinical practice. Another one would be a placebo contract, much like our pain contracts, that we could say, and we give the patient education about placebo, get them more on board with the idea, and if they're agreeable to it, say, I want the ability to potentially give you a placebo if I feel like it will benefit you. Please agree to this. You won't know when it's coming, and you know that it might still help you. And so that would be a way to maintain that relationship without deception. But the biggest opportunity that we have, in my opinion, is fostering the inherent placebo in the medications and procedures that we're already doing. So we know that medications have an active effect, but there's also these non-specific effects, placebo being one of them, that can really magnify the response. So first off, we saw from before that there's certain personality types. So some of it is going to be choosing the appropriate patients for these types of interventions. There's going to be responders and non-responders. So optimists, as we said before, versus pessimists tend to be non-responders. People with angry personalities have been found to be less likely to respond. But there are certain people that can almost without question be known to not respond. There was a study, it was also by that gentleman, Benedetti, who tried to induce placebo effect in Alzheimer's patients, and they found that it was not possible to induce the effect. And the theory here is that a strong connection between the prefrontal cortex and those deeper brain structures, especially the periaqueductal gray, are vital in order to get that response. So if there's so much brain mass that's lost, that signal really can't get through, and the placebo effect for analgesia anyway cannot be achieved. I did not find studies on this, but this may be applicable for certain stroke patients where strokes are in the prefrontal cortex, where we have traumatic brain injuries, that these also might be areas in which patients could be less likely to respond. We have some opportunities with conditioning. Patients have already been conditioned from their medical history at this point. So using previously successful therapy is sort of common sense medicine, but it also has good placebo research behind it, that if there's already buy-in from the patient, they're more likely to get a stronger placebo response in addition to the active response that they have there. Dose extension. So I briefly mentioned the therapeutic ritual of taking a pill. So we could consider, for patients that we think have a large placebo response, doing uncoupling combo medication. So rather than giving a Percocet every 6 hours, giving the acetaminophen, and then 3 hours later giving the oxy. So every 3 hours, the patient gets to participate in that therapeutic act of taking a pill. That can be achieved by lowering the frequency, increasing the frequency and lowering the dose. And also reinforcing the therapeutic message. So making sure that when inpatients are receiving their medications, that really the purpose of the pills that they're taking is being explained to them. Not just this is your Percocet, but really this pill is going to help your back. This pill is going to reduce your pain. So that message really is attached to that medication. Expectance was also something that boosted the effect of placebo analgesia. So physician enthusiasm, we have Dr. House positively glowing. And so what we bring into the room with us, how much we believe that something is going to work, the way we talk to our patients about therapy for them is, for placebo responders, something that's going to actually give them a better chance at a better outcome. So our enthusiasm can actually make our treatments better. Observed treatment. So this was really pretty wild. I came across a study where they gave patients saline, telling them that it was morphine, much like the Dr. Beecher story. They also gave them, in a separate time frame, morphine out of their site. So they already had an IV line in. They didn't know when the medication was coming. And they were able to determine that the degree of decrease in pain, just by believing you were getting the morphine, was equivalent to 6 to 8 milligrams of morphine that was received without the patient being aware of it. So just that observation, just that knowledge, I am being treated for my pain, can have a pretty significant difference. Placebo procedures work better than placebo pills. We're probably not going to be doing sham procedures in our clinical practice. That's not reasonable. But understanding that all the procedures that we do carry a large amount of those non-specific benefits. So just that the patient is undergoing this, for patients that are placebo responders, they're going to get a benefit. Obviously, we want to make sure we get the needle in the exact right spot every single time. And the chances that that doesn't happen, there's a good chance that the patient will still get a good response, if not the full response that we would hope. Certain patients have been shown to respond to brand or the price of medications. So this one was published in JAMA in 2008, and to really just kind of summarize it, they gave patients 2 pills for pain. They said this one costs 10 cents, this one costs $2.50. They didn't give them any more information, and what they found is that really across the intensity, that the expensive placebos worked better for the patients. So it may be reasonable in patients that are very reluctant to respond that maybe they need the brand, maybe they need the shiny the shiny capsule. Emotions obviously are big in the way that we of our bedside manner. So we've seen that stress reduction, anxiety reduction, all of those things can bolster the placebo analgesia. And so that in the inpatient or outpatient environment, that sometimes means having the right people on our team. So consulting neuropsychology, having psychiatry on board to address certain issues that may be interfering with how we're able to control pain. And some of this can be done with just our bedside manner, the way that we interact with people, the way that we can hopefully put people at ease. There's a placebo study on choice, and what they found was that they had two groups, patients that were assigned to a specific placebo, and then patients that were given 3 placebos to choose from. And the patients that chose the placebo, that had some kind of control in their treatment, had statistically significant improvements in their pain. So giving patients choice in their care can really do a lot to help patients feel like they have a little more control, reduce a little stress, reduce a little anxiety. And lastly, knowing what we know about nocebo now, is it reasonable to limit informed consent? So there was a study on, I think it was Flomax, where they had two groups. And one group was told this may cause erectile dysfunction. The other group was not given that information. And the group in the informed group had twice the rates of erectile dysfunction as the other group. So by giving patients information about something that a negative outcome that they may be exposed to, are we doing a disservice? For patients that we may think may generate these types of responses, do we want to limit it? Now it has to pass ethical scrutiny, but is it reasonable to say this medication has some side effects? I don't want to tell you what those are, because I'm concerned you might have them. So if anything feels strange to you, if you feel like anything is not quite yourself, call the office. We'll talk about it. We'll see if it actually has to do with your pill. But I don't want to give you a menu of problems that you can choose from. So obviously that has to pass some ethical muster. So in conclusion, placebos do have a real measurable and observable effect on pain and the brain. There are already physicians using placebo and impure placebos right now, and have been for thousands of years. There are obviously ethical concerns here. The physician-patient relationship is paramount. Using open label or disclosure or contracts may be an effective model to using some of these things that have been found in these studies. And finally, the physicians really can augment the inherent placebo in the active medications and treatments that are already being prescribed. So thank you very much to Dr. Van Wy, who advised me on this, to Brian for breakfast. This is my references, and any questions?
Yes. Excellent. I thought that was really interesting, by the way. But
Thanks.
2 quick questions. One, I found it interesting that you mentioned with the nocebo effect the involvement of CCK, and that's kind of a GI thing in my mind. And I was wondering if you saw anything in your research about the association between the nocebo effect and GI and food, or if there's anything there.
I did not come across that at all, but that's very interesting. This was really, sort of the only pathway. I didn't get too deep into it because, again, I think it could have been its own presentation. But now that you put that seed in my brain, I will probably go read about it. But no, I didn't come across anything.
All right. And then my second question is, being a DO, I'm a fan of manipulative medicine, but I also know that the research isn't super strong on it, and so I was wondering if, in looking things up, you found much in the way of manipulative medicine versus placebo? How big of a difference? I know it's kind of a broad topic, so I'm not sure if you have much.
Sure. I didn't look at it for this presentation, but I remember during school that it was something that came up a lot. And there were certain studies I remember for lumbar back pain that, especially that manipulation did very well versus placebo, but things like craniosacral did not do particularly well versus placebo. I don't have a percent or degree, unfortunately. He outranks you.
It's good maybe that you mentioned about the endorphins, the endogenous morphine in the brain, acting in the prefrontal, orbitofrontal, cingulate gyres, and positive in the periaqueductal brake, and so forth and so on. The question is there any study that was found that is it really true that the endorphins working on that by reversing it with naloxone or enhancing the effect of the apparent placebo effect, okay, with the use of an additional narcotic?
So I don't. I did not come across anything where they were giving an opioid and then seeing if there was enhancement techniques, if that had a significant difference over it. I did not see something there, but I think that's
Were they able to reverse it by, let's say, give you a placebo?
Mm-hmm.
I feel better. We're thinking that this may be coming from whatever in the brain going on. And you give an naloxone and you reverse it.
So there was only sort of the abortive one. So the naloxone before preventing the placebo effect. I didn't come across one where the placebo effect is happening and can we turn it off. I didn't see that now. But I think we have an fMRI somewhere we can try.
I was talking with Dr. North recently about the placebo effect, and he mentioned that in one case, I guess there was somebody receiving placebo, like malignancy, spontaneously. I know you're doing some pain, but did you come across anything non-subjective in your?
No, I mean most of those. There were a lot of sort of big results, but they were all kind of anecdotal or case studies. So sort of too much for to be totally attributed to the placebo there. I was tempted by a lot of different things to try and include them, but I tried to keep it as much pain as I could. Yeah.
In regard to the point about telling patients that this is going to help them with active medications are doing something to get additional effect with placebo. I was thinking about that when you said that if you had to sign a placebo contract as one option. It seems like to me, if you have them sign a placebo contract, that would take some potentially active medication that you are giving them, and they start questioning whether these are going to be effective. Was there any comment on the downside of doing a placebo contract?
So I actually didn't come across placebo contracts. This was something that I was like, hey, maybe this is something we can try. So I think there's a lot of potential because this is something so sort of airy. It's hard to get our hands on exactly what's happening here, and it seems so fragile. That's absolutely possible. Another thought I had is that if this became sort of a more common practice, would the increase in the placebo effect that we're seeing from that reverse pain studies, would that potentially be mitigated? Would we start to see a placebo effect that's decreasing because now there's less association with active medication and these placebos? But I think that's a totally valid point and something that would have to be sort of trialed patient to patient. Okay.
I thought that was a great talk.
Thanks.
I think it really covered a whole lot of stuff in a very short period of time. Pathophysiology, why this placebo effect might happen. As far as incorporating into your clinical practice, I mean, I think that's really kind of the base of what do we do with this? How do we do it? And I think it's pretty sophisticated. It's a pretty in-depth talk with a patient about, well, this is what I want to do. I want to start something that may or may not work. It may be a placebo, or it may not be. And this kind of my experience in my kind of 4.5 years of attending is that most people would not really be receptive to that population. They expect to be treated. They expect to have something. It's like, wait, you're going to tell me that you're going to give me something that's not going to work.
Mm-hmm.
Just kind of that response, it's really something that takes a lot of time. But you know, if you phrase it in the right way and with the correct patient population, might be useful. But I think in the now, I think the most important thing to me that I got out of this is really the interaction that you have with your patients. And that, none of this is denied. The suggestion that media and advertisement has on, well, this is going to help your pain clear if it helps all this stuff. It's cures everything. Whatever. Without using an actual placebo or even a partial placebo, saying something like, spending the time to say something and build some patient's expectations, like, look, I'm starting you on this medication, whatever, gabapentin, whatever those medication types. But saying, like, I expect this to work for you. I don't think there's anything ethically wrong with that. It's a medication that's used for pain, and you might be able, just from the power of suggestion, the interaction that you have with your patients, if you build that trust, to get away with using a lower dose, or to get away with, doing something. And that, to me, I think, is really the take-home message, is that this piece in the middle, like this whole emotional component, priming somebody for a treatment that will work, plays a huge role. And I think it kind of gets downplayed, especially in these clinical practices where you have, seeing 60, 80 patients a day, and just saying, how's your pain? What do we need to refill? Signing something and sending somebody out the door. It's a real missed opportunity to actually kind of take the time. Pain management is an incredibly complex thing. Without taking the time to speak with patients about it, believe me, I hate treating pain. It's the last thing I want to do. But if you take the time to do something like that, you're going to have more effect.
Can I just add on that? It's really interesting because the American College of Physicians is saying now that, the primary care physicians, not only the internists or the family physicians, but even now the physiatrists, people who are practicing in general physiatry, was quoted as one of the main sources of disseminating information about use of narcotics or the use itself of narcotics. I think we are not becoming a physician, this group, particularly the PMNR, is not becoming a group of thinking of other ways to look on some other improvements or management to relieve the pain of the patient, rather than just, well, they have pain, we'll give you gabapentin, we'll give you narcotic, we'll give you something. And I think we're forgetting something of, yes, developing the trust of the patient, yes, explaining to the patients whatever is going to be the effect of this management. But however, I think if you can incorporate this really in your practice, which may take time to explain, asking for consent and so forth and so on. And maybe some institution probably would say, you have to go through ethical committee for this kind of management. But if you can incorporate it, maybe wise really, rather than just giving you a prescription of oxycodone, dilaudid, whatever it is, here's 5 milligrams, and I hope I'll see you next month, but another prescription comes. But I think it's just a matter really of real explanation. Yes, choosing the right patient. And there's really a choosing of nociceptive as well as, cognitive, emotional, and some other things that you have to consider.
I was just wondering, I know there was a lot of broad strokes, because of the nature and the size of the subject. I wasn't sure that I noticed anything in regards to chronic pain. It seemed like a lot of the studies were focusing on kind of acute pain, and so I was just wondering, maybe I missed it. Was the placebo effect looked at a lot in the research for chronic pain?
So unfortunately, because a lot of things with the fMRI, we're looking at sort of immediate reactions. the induced pain that was sort of reproducible was kind of the mode of choice. I noticed the same gap, and I spent the last week really trying to find something to fill it. There are fMRI studies of the brain of chronic pain patients, so showing decreased activity in the prefrontal area and some excitability in the thalamus and anterior cingulate cortex, which would correlate with what's really being talked about here, that if we really can downgrade that activity, if the wiring is still in place, then it should still direct it. But I did not find something that directly said, with chronic pain patients. And that was, but yeah, I absolutely saw that was needed. Yeah.
Thanks.
Oh, thanks.